Welcome to Podcast 6. We've gotten through all of the foundational and introductory material, and now we're getting into some cases. This podcast is going to address three things. By the end, you should be able to identify common or serious injuries to the shoulder girdle, recall the important stabilizers of the shoulder articulations, and generate a differential diagnosis for a patient presenting with trauma-related shoulder pain. So Devin is a 21-year-old male, right-hand dominant, and a U of C student who wiped out badly while snowboarding this afternoon. He has pain in his right shoulder area and previously enjoyed full and normal function. He's otherwise healthy. Thinking about what's in the shoulder girdle, what are possible injuries he could have sustained? Remembering Rule 1 and Rule 2, we can consider each segment of the shoulder girdle to generate this list. Why don't you pause the playback and come up with a quick list before we roll through each of these. The sternoclavicular joint and scapulothoracic joints will be included in bonus material at the end. So, clavicle fractures are really common. At least one person watching these podcasts will have direct personal knowledge of this. Common mechanisms include biking, road, mountain, dirt, etc., skiing, snowboarding, and hockey. Despite the fact that the clavicle sits right on top of all the important stuff, serious neurovascular injuries are rare. Despite the fact that there isn't much meat over the clavicle, open fractures are rare in my world. Key clues are the swelling and deformity over that midshaft clavicle and a sense of crunching reported by the patient. Most of these injuries can be treated with a sling and time. There continues to be controversy about who should get surgical fixation, so if any doubt, get expert help. In general, minimally displaced fractures do best with non-operative treatment. It just takes time. Things that would push me to surgery are on this list. The top radiograph shows a fracture much more likely to get an operation than the bottom one. There are nuances to these indications that are beyond the scope of this course, but certainly classic ones would be open fractures, badly displaced fractures, fractures that are part of a polytrauma situation, and painful non-unions, which is what happens when the fracture doesn't go on to heal. In summary, these are common and you should know they exist. Most do well with non-operative treatment, and everyone can start out that way if you need to get an expert opinion. Moving right along, we have the AC joint. Just like clavicle fractures, these are unbelievably common injuries, classically from a direct blow to the corner of the shoulder. Biking of all types, skiing and snowboarding, and hockey are again the common activities and mechanisms. When you look these up, you'll often be confronted by a diagram like this with all sorts of arrows. Don't worry about this. Let's take it back to the layers and stabilizers. Low-grade injuries affect the AC ligaments only, either with a simple strain leading to no displacement, or a disruption leading to a small amount of displacement at the AC joint. These require rest, ice, and a sling for comfort for a few days. Some people will need some active rehab, but in general these are fairly benign. The most common injuries that I see in shoulder clinic are these. The AC ligaments are gone and the CC ligaments are gone. With wild amounts of displacement, it is possible to have some tearing of other superficial fascial structures as well. Functionally, these are not really distinct categories, but really a continuum. Treatment is controversial, but I typically give everyone a good go at rehabilitation and reconstruct those who fail, which is certainly much less than the total number of these that I see acutely. These other two are red herrings. Call someone if you find one. As before, these are very common, and the appearance on radiographs will tell you what structures have been disrupted. AC ligaments only, or both AC and CC ligaments. So we're on to the glenohumeral joint, which manifests two broad categories of injury. Dislocations are either anterior, which is 95% of the time. We're on to the glenohumeral joint, which manifests two broad categories of injury. Dislocations are anterior 95% of the time or posterior, and fractures can be either of the proximal humerus, which is the majority, or of the glenoid, which is relatively rare. Anterior shoulder dislocations are extremely common, affecting about 1% of all people. Injured structures can include the anterior-inferior labral tears, avulsion of the capsule and ligaments, or fractures of the back of the humeral head, called a Hill-Sachs fracture, or the front of the glenoid, called a bony Bankart. The shoulder contour will be abnormal clinically. You want to document a neurovascular exam, and then that shoulder needs to go back in joint ASAP. You still have to examine them afterwards, and you need to get good x-rays. The younger a person is at the first dislocation, the more likely it will go on to be recurrent. Any single dislocation increases your lifetime risk of shoulder osteoarthritis. Posterior dislocations are rare, and because of this, you need to remember to look for them. The same lesions can happen, but on the opposite sides of the shoulder. The classic associations for mechanism are seizure events, electrocution events, and North American football. One of the most classic findings clinically is that the patient cannot externally rotate their arm either actively or passively because the humeral head is impaled on the posterior glenoid, trapping it. It's reasonable to call for help to get a reduction, as there's some careful technical aspects involved. So, let's look at some shoulder stabilizers. In any joint, there are structures that provide static and dynamic stability. Static stabilizers are constantly active and are not adaptable. In the shoulder, these are the static stabilizers. We've got bony shape, concavity compression, capsule, labrum, ligaments. Dynamic stabilizers act on demand and are adaptive to a given situation. Rotator cuff muscles and scapular muscles are the motors, and the proprioceptive data from joint position receptors and tendon receptors are harnessed to drive that communication loop. Sometimes loss of one type of stability can be compensated for by the other, sometimes not. Static stabilizers need structural solutions, while dynamic stabilizers may need either focused rehabilitation or structural solutions if the stabilizers themselves are torn. This is a good topic to know something about. Glenoid fractures are rare outside of Bankart fractures, and it's reasonable to get expert advice. In summary, glenohumeral dislocations are common injuries that require emergent reduction of the dislocation. Proper care involves good documentation and adequate radiographs after you put it back in joint. And you can review the podcast on shoulder x-rays to review what this means. Sling and rehab are mainstays, and sometimes surgery is required. So after you assess Devin, you find he has a deformity over the middle of his clavicle. He's neurovascularly intact, and his x-rays confirm the midshaft clavicle fracture. You give him a sling, instruct him to ice the area, and refer him to orthoclinic for follow-up. As a final thought experiment, if Devin was really Jeff, a 50-year-old middle executive with a first-time shoulder dislocation, he might be at risk for a soft tissue injury as well. We'll get to this in the bonus material. This has been a pretty comprehensive list of fractures and dislocations of the shoulder. We didn't cover the proximal humerus fracture here, and there's a little bit more on this in the Carol's first bad day case. You can draw some conclusions about examination study from how much time and attention was given to each injury. So this is the end of regulation time. You can stop the podcast here if you've had enough. There is bonus content that follows immediately and covers the two articulations that we haven't yet. So this material is bonus. It'll be useful for you if you have an interest in orthopedics, in emergency medicine, or are rotating in those areas. Sternoclavicular joint also can have two basic things happen to it: dislocation or fracture of the clavicle just lateral to the joint. None of these injuries is really common. Classic mechanisms are contact sports like North American football, motor vehicle collisions, or occasionally ski/snowboard injuries. This slide shows the quick info on anterior sternoclavicular dislocations. They're fairly benign, but they can become chronically unstable if the SC ligaments don't recover because the bony shape of the sternoclavicular joint affords no basic stability and there's no muscles. The classic dangerous injury here is a posterior sternoclavicular joint dislocation, mostly because it lives in a bad neighborhood with all the important stuff. This does require emergent attention and expert assistance. This is one joint that's really hard to assess with regular x-rays, so we go for the fancy tests if you have a clinical suspicion. In younger patients, such as those under 25, a dislocation may actually be a fracture through the physis. These will generally resolve without specific intervention, but they're rare enough that it's reasonable to ask for expert help. Medial clavicle fractures are pretty uncommon and usually do heal up on their own. However, they are on my PETA list because failure of healing is a real problem to treat if it happens. This is not a topic you need to spend much time on right now, but if you do intend to work in an area such as an urgent care or emergency room, you do need to know these exist. This is super bonus for completeness. Scapular body fractures aren't common as isolated injuries. If you see one, though, you should assume that the thorax has taken a hard hit, and you need to think about rib and other chest injuries. Grab an expert opinion for guidance. Scapulothoracic joints can become dislocated or dissociated, and these are really rare injuries, and typically when the patient has one of these, they have much bigger problems. In essence, the whole forequarter has been ripped off. It's a catastrophic injury, and I've never seen one. If you work on the trauma team, potentially you'll run into this. It may not be an issue if the patient doesn't survive. So, as a little bit more detailed follow-up of this very non-quantitative graph that we threw in there right at the end, this is to show you that the consequences of shoulder dislocations change as the patient's age increases at time of first dislocation. Pain from a dislocation should settle fairly quickly unless there's a proximal humerus fracture, in which case it might be a couple of months. So if you have a middle-aged or older person without fracture and a simple dislocation, and they continue to be painful with poor function after 3 to 4 weeks, start to think about associated soft tissue injuries like rotator cuff. You can follow along in the Elmer case or the Carroll case for guidance.